Welcome back. We're so glad you're joining us for another custom-tailored deep dive because today we are getting into the science of everyday health. And, well, if you have eczema, there is a very good chance that the unscented lotion you're buying to soothe your skin is actually secretly triggering your flare-ups.
Yeah, it's wild how common that is.
Right. Today we're looking at atopic dermatitis. It's, commonly known as eczema.
Yeah.
And it is universally misunderstood. It gets constantly brushed off as just dry skin.
Which is incredibly frustrating for patients.
Exactly. And it's surrounded by this incredibly profitable industry of misleading skincare marketing. But anyone who has experienced that relentless bone-deep itch, they know it is a chronic inflammatory battle.
And it's a battle that most people are honestly fighting with the wrong weapons. I mean, when you look at the actual clinical guidelines and the medical literature, you realize pretty quickly that common dermatological wisdom is completely backwards.
Like what?
Well, we have patients buying these really expensive, useless barrier creams, right? While completely ignoring highly effective non-pharmacologic strategies.
Yeah.
Like, for instance, taking a bath in heavily diluted household bleach.
Okay, let's unpack this because we are definitely going to explore that bleach protocol later. It sounds totally absurd, but the science behind it is fascinating.
Oh, it really is.
So our mission for this deep dive is basically to cut through the marketing noise of the skincare aisle. We want to ignore the hype and uncover the medically backed strategies for managing atopic dermatitis from the ground up. So before a clinician even prescribes a single pill, how do they actually begin to tackle this?
Well, that foundation begins with accurately measuring the disease because, you cannot manage what you don't understand.
Makes sense.
And atopic dermatitis is a multifactorial process. You aren't just looking at dry skin. You are dealing with a hypersensitive immune system, a severely compromised physical skin barrier, and an imbalance in the natural microbes living on the skin.
So it's a whole cascade of issues.
Exactly.
Yeah.
Physically, this presents as erythema, which is the clinical term for intense redness, oozing, crusting, and lichenification.
Lichenification, what is that?
It's where the skin literally becomes thick and leathery from the constant trauma of scratching.
Oh, wow. So the itch really is the engine of the disease.
Yes. And if a clinician is trying to figure out how bad the condition is, just looking at a patch of red skin doesn't tell the whole story.
Right, because I know in clinical trials, they use these incredibly complex microscopic measurement tools, things like ESA or the SCORAD scales, to calculate the exact surface area of the rash.
Right. But in the real world, a doctor has maybe 15 minutes with a patient. They don't have time for a microscopic surface area calculation.
So what do they use?
Which is why the clinical standard in everyday practice is a tool called the PUOM questionnaire. That's the patient-oriented eczema measure.
Patient-oriented, I like that.
Yeah. It is entirely focused on the patient's lived experience. It takes less than 2 minutes, and it scores symptoms from 0 to 28 over the past week. It evaluates the intensity of the redness, sure, but more importantly, it quantifies the invisible toll. It measures sleep disturbance. It asks how many days the skin was actually bleeding or weeping.
So it's basically quantifying the misery. I mean, a patient might have a really small patch of redness, but if they are waking up with bloody sheets because they've been tearing at their arms in their sleep, their disease state is profoundly worse than someone with a much larger rash who sleeps soundly.
Precisely. Understanding that misery index is step one. Step two is addressing it through education.
Education, not medication.
Exactly. We have this incredible piece of literature detailing a massive randomized trial. It involved 992 children and adolescents with atopic dermatitis.
Almost 1,000 kids. That's a huge trial.
It really is. And they compared standard care to a 6-week multidisciplinary education program. And this was led by dermatologists, psychologists, and dietitians.
I mean, 6 weeks is a serious commitment just to learn about a skin condition. But treating eczema without patient education is, well, it's like handing someone a leaky boat and a patch kit, but never actually teaching them how to row or look for rocks.
That's a great way to put it.
You can hand out steroid creams all day long, but if the patient doesn't understand their own skin barrier, they are just going to keep sinking.
And what's fascinating here is that the results of that trial prove your point perfectly. A full year after the program ended, the children who received the education showed significantly greater improvements in their physical disease severity compared to the control group.
Wait, a full year later they were still doing better?
Yes, they physically healed because they finally understood the medical mechanisms of their condition. They developed better psychological coping strategies, which directly led to less scratching behavior.
So knowledge literally translates to clearer skin.
It really does.
And the very first test of that knowledge happens every single day when a patient has to choose how to hydrate their broken skin barrier.
Right, the moisturizers.
Yeah, because the clinical rule is that emollients, medical moisturizers, need to be applied at least twice daily, ideally right after bathing while the skin is still damp.
Hmm.
But you walk into a pharmacy and the shelves are just a minefield. You've got ointments, creams, lotions, oils.
It's overwhelming. But the science of those formulations comes down entirely to water content. Ointments, like pure petroleum jelly, contain zero water.
None at all.
Zero. They are incredibly thick, they sit heavily on top of the skin, and they offer the absolute best protection against moisture evaporating from that compromised barrier.
Okay, but they are aggressively greasy. I mean, the reality of putting on a tailored suit or a silk dress after slathering yourself in petroleum jelly, that's tough.
It's a sensory nightmare for a lot of people.
Exactly. So people naturally gravitate down the ladder to creams, which have low water content, or lotions, which are mostly water.
Right. And generally, the best moisturizer is the one a patient will actually tolerate using consistently.
Sure, adherence is key.
However, while thick ointments are clinically superior for trapping moisture, the guidelines point out a major biological exception, and that is folliculitis.
Which is what?
It's an inflammation of the hair follicles. If a patient lives in a hot, humid environment, or if they just sweat heavily, smearing a thick, non-breathable ointment all over their body traps the heat and the sweat against the skin.
Oh, that sounds awful.
It is. It triggers an infection of the hair follicles. So in those specific scenarios, lighter creams or lotions are medically preferred.
Okay, so the texture is one thing, but here's where it gets really interesting. The real deception happens on the ingredient label.
Oh, absolutely.
Because when people have sensitive skin, they naturally look for a bottle that says unscented, but the data shows this is a massive trap.
It is a profound manipulation of language. Consumers use the terms fragrance-free and unscented interchangeably all the time. But chemically, they represent completely different manufacturing processes.
Okay, lay it out for us.
Fragrance-free means exactly what it sounds like. No fragrance materials were added to the product whatsoever.
Wait, so what does unscented actually mean from a chemical standpoint?
It means the raw ingredients of the product naturally smell bad.
Really?
Yeah, they might smell intensely of chemicals or raw fats. So the manufacturer actively adds additional masking chemicals into the formula. These chemicals neutralize the bad odor so your nose doesn't detect anything.
Wait, so unscented is basically just sweeping chemical dirt under a chemical rug.
Pretty much.
I mean, it's like putting a chemical invisibility cloak over the raw ingredients. Your nose can't see the smell, but your hypersensitive immune system still detects all those foreign masking chemicals and mounts an attack.
Exactly. You're actively applying synthetic triggers directly onto an open, broken skin barrier. And those specific masking chemicals are notorious sensitizers. Wow. They trigger allergic contact dermatitis, which sets off a massive eczema flare.
That is infuriating. Are hypoallergenic labels also lying to us?
Unfortunately, yes. Emollients marketed as hypoallergenic do the exact same thing. It is completely unregulated as a marketing term. Completely. Studies consistently find potent chemical sensitizers in products labeled hypoallergenic. You basically have to ignore the front of the bottle entirely and read the actual ingredient list on the back.
When you realize companies are actively hiding chemicals under these labels, you really start looking at every marketing claim differently.
Yeah.
Especially the ceramide hype.
Oh, the ceramides.
Yeah. It seems like every expensive lotion now boasts that it's packed with ceramides to rebuild the skin barrier.
Well, the logic seems sound on the surface, right?
Yeah.
Patients with atopic dermatitis have a natural biological deficiency in ceramides.
And ceramides are what, exactly?
They're a specific type of lipid, or fat, that helps hold the skin barrier together.
Right. So if my skin is a brick wall and the ceramides are the mortar, it sounds totally reasonable to buy a lotion full of ceramides to replace the missing mortar.
Intuitively, yes.
Yeah.
But human biology is far more complex than a brick wall. The human skin barrier relies on hundreds of different types of ceramides, all synthesizing and interacting within this highly complex biological matrix.
Oh.
The clinical guidelines state definitively that there is no proven benefit to moisturizers marketed as containing ceramides over standard, inexpensive emollients.
Really?
None. None. Slapping a few isolated synthetic ceramides from a plastic bottle onto your skin does not magically integrate into and replenish the intricate biological deficiency of the epidermis.
Wow. So it is just a massive upcharge for an illusion of healing.
Basically, yes.
Okay, so we've navigated the moisturizers. We want a true fragrance-free ointment or thick cream, and we apply it immediately after bathing. But water itself is a notoriously difficult variable with eczema, right? I mean, it can hydrate the skin, but it can also destroy it.
Exactly. The physical act of bathing requires strict boundaries. Baths or showers must be kept under 10 minutes, the water must be lukewarm, and should really only happen once a day.
Why lukewarm?
Because hot water is incredibly efficient at stripping the skin's natural lipids. It severely worsens the dryness and the structural breakdown of the barrier.
Right, so since water strips the skin, it makes sense that patients try to fortify their bathwater. You want to add that missing moisture back in while you soak. Which is why emollient bath additives like bath oils and liquid paraffin are a huge industry.
They are heavily marketed, but the data dismantles their medical value entirely.
Really?
Yeah, there was this comprehensive 52-week study,
A whole year?
a full year. It tracked 463 children with mild to moderate eczema. Half of them used these expensive emollient bath oils, and the other half used standard washing protocols.
And the result?
After a full year, there was absolutely zero clinical benefit.
Zero.
Zero. The severity scores for the bath oil group were completely identical to the control group. In fact, the only documented outcome of the bath oils was making the bathtub dangerously slippery, creating a serious physical hazard.
Oh my gosh, so we just pour the expensive oils down the drain. What about colloidal oatmeal?
Now, colloidal oatmeal is the singular exception supported by the literature.
Okay, good to know.
It possesses genuine, documented anti-inflammatory properties. It actively soothes the localized immune response in the skin, and as a bonus, it doesn't turn the tub into an ice rink.
Perfect. Okay, but looking at the clinical guidelines for moderate to severe eczema, I need to stop the conversation right here. I need to ask, we're telling people to bathe in the same bleach they use to clean their toilets. How is that not destroying their already compromised skin?
I know, it sounds incredibly destructive. But dermatological societies widely recommend it because it is cheap, accessible, and highly effective.
Ow.
The critical mechanism here is the dilution. We were talking about a microscopic concentration.
What's the formula?
The formula is precisely half a cup of 6% household bleach in a full 40-gallon bathtub of lukewarm water. Or, if you're using a smaller basin, it's 1 scant teaspoon per gallon of water.
Half a cup spread out over 40 gallons of water. Okay, so at that dilution, the chlorine concentration is basically identical to a municipal swimming pool.
Yep.
But what is it actually doing biologically? Because eczema patients are highly prone to staph infections on their broken skin. Is the bleach just, like, carpet bombing the skin to kill off the bacteria?
If we connect this to the bigger picture, that was the assumption for decades. Doctors genuinely believed the bleach was acting as an antimicrobial. They thought it was specifically targeting and killing the Staphylococcus aureus bacteria that colonizes the compromised skin.
That makes logical sense.
It does. But recent in vitro studies and trials have revealed the true mechanism, and it is far more elegant. At that specific weak dilution, the bleach does not actually reduce the bacterial load at all.
It doesn't kill the staph.
It doesn't kill the staph.
Then why does the skin clear up?
Because heavily diluted bleach exerts a direct anti-inflammatory effect on the skin cells themselves.
Oh, wow.
Yeah, it essentially acts as a chemical signal that turns down the dial on the localized immune response. It reduces the erythema and the pruritus, the itch, without wiping out the skin's natural healthy microbiome. It functions as a chemical soothing agent, not an antibiotic nuke.
That is amazing. That completely flips the script on how we view harsh chemicals versus medicine.
It really does.
Speaking of intense hydration strategies, the guidelines also detail a process called wet wraps to break these severe flare cycles.
Yes, wet wrap therapy forces moisture into the barrier through occlusion.
How does it work?
A patient applies a thick emollient, then puts on a layer of damp cotton clothing or dressings, and follows that immediately with a dry layer of clothing over it.
So you're literally trapping the dampness against the skin for hours, preventing any evaporation.
Exactly. The cooling effect instantly dulls the nerve endings, which stops the scratching, while the trapped moisture physically plumps the dead cells of the stratum corneum, that's the outer layer of the skin.
That sounds incredibly relieving.
It is. Now, clinicians sometimes have patients apply low-potency topical corticosteroids under these wet wraps for short 10 to 15-minute intervals. But the literature provides a massive warning here.
What's the warning?
Because the wet wrap hydrates the skin barrier so thoroughly, it opens the channels of the skin. This drastically increases the absorption rate of the steroid.
Wait, so a mild topical cream suddenly becomes like a systemic dose because the skin is acting like a sponge instead of a shield.
Exactly. It has to be heavily monitored to prevent too much steroid from entering the bloodstream, which is why it's usually capped at a maximum of 3 times a day for just 3 days.
Okay, so we have the hydration protocols, the bleach baths, the wet wraps. But to maintain clear skin long term, we have to navigate the minefield of everyday triggers.
Right. Stopping the flare before it starts.
Yeah. Why does the skin suddenly erupt in the first place? I mean, some of these are straightforward environmental factors, like low humidity in the winter, sucking moisture from the air, or hard water from a shower.
Sure. Contact triggers are also deeply specific, though. Take lip lickers dermatitis.
That sounds painful.
It is. Human saliva contains potent digestive enzymes. So if a child is constantly licking their lips, those enzymes sit on the face and literally begin digesting and breaking down the already fragile skin barrier.
Oh my God.
That result in this painful, raw ring around the mouth. Alcohol-based hand sanitizers do something similar. They instantly strip the vital lipids from the hands, destroying the barrier function.
But when patients think of triggers, they almost universally think of allergies. And this is where the medical literature reveals a massive disconnect.
It really is a profound point of confusion for both patients and general practitioners alike. I mean, it is incredibly common for eczema patients to take an allergy prick test and light up with positive results for dust mites, animal dander, or specific foods like milk, egg, wheat, and peanut.
And the logic follows, right? I tested positive for a peanut allergy. My skin is flaring up. Therefore, the peanuts are causing the eczema.
But the clinical literature shows that aggressive avoidance measures like ripping up all the carpets in a house or putting a child on a highly restrictive elimination diet rarely stop the eczema. Really?
Yeah. For the vast majority of patients, food sensitization is clinically irrelevant to the actual course of their atopic dermatitis.
So, what does this all mean? I mean, I feel so bad for parents who put their kids on these torturous restrictive food diets for no reason. Can you clarify why a positive allergy prick test doesn't equal an eczema flare-up trigger? This requires a biological explanation. Why would my blood show elevated IgE antibodies for a peanut allergy, but eating a peanut doesn't actually trigger my skin to break out?
Because a systemic food allergy and a localized eczema flare operate on completely different biological pathways.
Okay.
When you do a skin prick test, you are physically bypassing the skin barrier and introducing an allergen directly to the immune cells, triggering those IgE antibodies to react.
Right.
But eczema is primarily a structural defect of the epidermis. Your skin barrier just lacks the proteins to keep environmental irritants out. When an irritant breaches the skin from the outside, localized T cells mount an inflammatory attack.
I see. So having a systemic immune recognition of a food protein in your gut does not mean that food is actively destroying your skin barrier from the inside out.
That is a massive paradigm shift. Basically, do not starve your child or restrict their diet trying to fix a structural skin defect without consulting a specialist first.
Absolutely not.
So if we understand the triggers, what is the actual clinical algorithm when a severe flare happens despite all our behavioral management?
Well, the clinical flowcharts dictate a response based entirely on the anatomy of the flare and the severity of the localized immune response.
Anatomy meaning where it is on the body.
Exactly. If the eczema appears on sensitive areas like the face, the neck, or the groin, the protocol strictly calls for low-potency topical corticosteroids.
Why only low potency?
Because the skin in those areas is naturally very thin, and because steroids inherently cause skin thinning or atrophy over time, using a high-potency cream on the face could cause permanent structural damage.
Oh, wow. But what if the flare's on the main body, like the arms, the trunk, the legs, where the skin is much thicker?
Then the clinician returns to the PUM score we talked about. If the score shows mild disease, they stick with low-potency steroids.
Oh?
But if the PUM score reveals moderate to severe disease, so cracking, bleeding, deep inflammation, the localized immune response is just too strong.
A low-potency cream won't cut it.
Right. It won't break the cycle. The algorithm dictates stepping up to a medium or high-potency topical steroid for 2 to 4 weeks. You essentially have to use a chemical sledgehammer to force the immune system to stand down.
But you can't just swing a sledgehammer forever.
No, definitely not. Once the skin is clear, the patient drops into a maintenance phase.
What does that look like?
They continue the heavy daily emollients, but they use the topical steroids intermittently, just 2 to 3 times a week on the areas prone to flaring.
Ah, okay.
This keeps a chemical lid on the inflammation, preventing the embers from reigniting. Now, if the disease still doesn't respond after that, the clinician must pause.
To do what?
They evaluate if the patient is actually adhering to the routine. They check for underlying bacterial infections, or they escalate to a specialist for systemic immunosuppressant drugs.
It is a relentlessly methodical approach, so if you're battling that relentless itch, it might be time to completely rethink your routine. Toss the dangerous, slippery bath oils, save your money on the overpriced, biologically incompatible ceramide creams,
Absolutely.
and learn the vital mechanism of contact dermatitis so you never fall for a label that says unscented again. Keep your showers lukewarm and under 10 minutes, lock that moisture in with a thick, waterless ointment, and of course, respect the highly effective anti-inflammatory power of a heavily diluted bleach bath.
This raises an important question. Looking at the totality of what we have covered today, it is profound to consider how much of treating a deeply physical, painful skin condition relies entirely on behavior, education, and having the knowledge to separate scientific fact from commercial fiction.
It's so true.
The topical creams are only a fraction of the actual cure.
Which brings us to a final underlying mechanism to consider. We noted earlier that the successful education program taught psychological coping skills.
Right.
And the source material explicitly states that psychological and emotional stress directly activates neuroendocrine mechanisms in the body. When you experience stress, your brain releases stress hormones and neuropeptides. These chemicals travel through the bloodstream, bind to specific receptors in the skin, and literally trigger the nerve endings to feel the physical sensation of itch.
It's a direct loop.
The brain chemically commands the skin to flare up. So if our minds can physically manifest a compromised skin barrier, could the future of treating chronic skin diseases rely just as heavily on managing our nervous systems as it does on applying topical creams? If the skincare aisle is a labyrinth of false promises, maybe the ultimate way out isn't finding the right chemical formula in a bottle, but finding a way to chemically calm the mind. Thank you for joining us on this deep dive. Take care of your barrier and always question the label.